Uh, Assalamu alaikum and good evening to Honorable Chairperson, my respected teachers and fellow orthopedicians. So today's presentation is about osteogenesis imperfecta. I'm Dr. Quaisur Rabbi, currently working as a pediatric orthopedic surgeon in Health and Hope Hospital. So we all know osteogenesis imperfecta. It's also known as Lobstein disease, brittle bone disease. Sometimes it's called Brugger syndrome, fragile bone disease. In many ways, the core thing is the production of bone is imperfect. And what is making that imperfection? The imperfection is about the collagen that's present in osteoid. When the mesenchymal cell transforms themselves into osteoid, they defects in collagen 1, the base content of the osteoid cell. This collagen 1 is presented in chromosome number 17. It's the long hand of chromosome 17. It produces faulty amino acid. That faulty amino acid substitution makes that collagen defective, and the osteocyte that produced from osteoid is also defective, causing weakening of the tissue. So what we are talking about, where does this collagen 1 uh, lives in our body? It's mainly the structural unit of our body. Like type 1 collagen is presented in bone, skin, dental tissue, that means tooth, cornea, blood vessel, fibrocartilage, and tendon. Almost the infrastructure of the body is built up by this collagen 1. So whenever we will find a patient with osteogenesis imperfecta, we can find deformity or problems within these tissues. Most of the time, we get patients with fragile bone with deformed limb bones. Mainly the long bones are deformed. How the patient will present to us depends on severity of the expression of that mutated gene and pattern of inheritance. Mostly these people, these childs comes with defective dentation. Sometimes they comes with modified or angulated bones, long bones, as this picture shown, sometimes with triangular faces. It depends on which part of the body is severely affected and the pattern of inheritance, whether that's autosomal dominant or autosomal recessive. So scientists have previously tried to classify this, and this classification started since 1906. Loser first tried to classify this as osteogenesis imperfecta tarda and congenita. That means congenitally present or then detected afterwards. And then after a long period of time in 1949, Seedorf then classified osteogenesis imperfecta tarda into two subgroups, osteogenesis imperfecta tarda gravis and levis. Then his cases, like gravis, is those patient or those child who was diagnosed with fracture or bone bowing before 1 year of age, and those who were diagnosed after 1 year of age, those are diagnosed as osteogenesis imperfecta tarda levis. But it seems incomplete. Then Falvio and his associates classified that with type 1 and type 2. Type 1 means those patients or child who is coming with bowing of the bone, and those without bowing is type 2. But the good classification or accepted classification comes from silence. The silence, what did is he classified this osteogenesis imperfecta according to severity of the expression of the gene that was mutated and pattern of inheritance, whether it was autosomal dominant or recessive. So initially, he classified this into 4 subtypes, type 1, 2, 3, and 4. All these are due to collagen 1 deficiency, mainly collagen 1A1 and collagen 1A2. Though collagen 1A1 is the main collagen that is defective, but sometimes they also found that collagen 1A2 is also defective, and that's causing much more problem. And all these types, he mentioned that all these are autosomal dominant. And then after a long period of time in 2006, Morello found another gene which is also responsible for doing osteogenesis imperfecta or creating osteogenesis imperfecta. What he said is CR-TAP is also responsible for creating osteogenesis imperfecta, and he termed that as a silence type 7. And after 1 year, just after 1 year, in 2007, Cabral also proposed that LEPRA1 gene is also responsible for creating osteogenesis imperfecta, and it was classified as osteogenesis imperfecta type 8. Among these, the type 1 is easily available, and most of the time it's type 1 with not that severe presentation, and type 2 is prenatally lethal. That means those child with type 2 osteogenesis imperfecta are either died in utero or just after birth or within few months or weeks after birth, with severe bone deformity and all the clinical feature that I have shown are in my earlier slides. So what Cabral also found that LEPR1 gene is also responsible for, in some cases, to cause osteogenesis imperfecta type 2 and 3. If LEPR1 gene is absent in fully absent in child or babies presented with, they may suffer lethal uh, problem in case, and that was classified as silence type 2 and 3. So what is the diagnostic tool that we can diagnose osteogenesis imperfecta with? To my sense, it's like the clinical feature will talk about itself. Clinical feature is the most uh, important diagnostic tool. Along with that, we also use X-ray. We can also use DEXA, though DEXA scan sometimes can be misleading because the DEXA machine that we use, dual energy X-ray absorptiometry, that is set up for patient above 18 years or more. And so when we want to go for DEXA scan in case of children with 1 to 2 years or 5 years, that machine sometimes gives false result. Along with that, we can go for DNA sequencing of the collagen sample that we can acquire from the blood, and also we can take collagen samples from the skin and get biochemical and histopathological testing to find out whether that baby is suffering with osteogenesis imperfecta or not. Intrauterine chorionic villus sampling, amniocentesis, synthesis, and sometimes 4D or 3D ultrasonogram can also detect osteogenesis imperfecta in their early or prenatal scan. In 20 weeks scan, we can get a good picture in ultrasonography. And amniocentesis and chorionic villus sampling is almost 100% accurate to find out whether that child is suffering from osteogenesis imperfecta or not. So in X-ray, what we'll find a lot of things, but it's not necessary that one child will bear each and every features that X-ray can show. Most of the time, it's like long bones, which are either broken in multiple segments, but there will be some irregular or various stages of healing. Along with that, bowing of the long bone will be there. Mainly the metaphysis and the diaphysis will show the same diameter with thin cortices, with some popcorn calcification at the metaphyseal and in the epiphyseal region. Sometimes those child who are actually not moving that much, they will show some cystic honeycomb pattern in the long bones at the end. In case of the face or skull, they will show the helmet or mushroom appearance. I'll show you some pictures so that this will be clear. Sometimes they will show Overmian bones also. And those childs who are mobile, sometimes they got protrusion of the acetabuli in the inside, and uh, bowing in, or not only in one plane, it's multiplanary bowing is there. So let's see some x-rays. These are like, as I was saying, the bowing will be there with easy fractures, which you can hardly explain how did it happen. But we need to be cautious, because sometimes battered baby usually present with this type of fracture at too early these stages. Other than that, as you are seeing in this picture, the cortex is thin as the metaphyseal diameter, and the diaphyseal diameter is almost same with one fracture, which is also healing, but with lots of callus is there, but it's not healing properly. Like this, sometimes we find when these childs are mobile, the spine is collapsed, like as the bone is soft, the spine seems collapsed. Sometimes the child present with x-rays like this. It looks like a x-ray of a serpentine. The all the long bones, that means both the femur and the tibia fibula is bowed, as if it was bent with some metal or something else, some machinery. Sometimes they present with only honeycomb appearance like this. As I was telling, these childs who are not mobilizing that much, or maybe due to the disease process, they are not moving that much. They usually present with joint space and the diaphysis like this. As I was telling, uh, those child who are moving, acetabulum sometimes shows protrusive acetabuli like this, with acetabulum invasionating inside the pelvis. And sometimes they also present with fracture. Not only this single fracture, there may be multiple fracture with different age of healing. All are not in the same time. And this is what I was talking about, the helmet skull, right? The frontal bone on all the bones of the skulls are bossing, then the mandible is small, the ear is situated way below. The nose is also deformed. In this case, I can't show you a live picture or clinical picture of the baby, sorry. These are the other tests that we can do, or we can perform to find out or make sure that these children are suffering with osteogenesis imperfecta, to find out that he or she is not suffering with any other disease condition that we are diagnosing wrong. These are the diseases that can mimic the osteogenesis imperfecta. Sometimes achondroplasia, osteoporosis, though in child osteoporosis is not that much common, but we'll also get the X-ray look like osteoporotic. Rickets is also a chance that patient may be suffering with rickets also. So after diagnosing, so we need to treat the patient, but what options do you have? Uh, the main or the most important part, what I think about treating osteogenesis imperfecta or a child suffering with osteogenesis imperfecta, is counseling the parents. I have seen parents who are fed up after one or two fractures about regarding their child. And I have also seen parents who are easily coping up after 17 fractures in consecutive 6 years. And they are still hoping for the best for their child. So we can classify or um, we can uh, we can divide the treatment option into either medical treatment or supportive treatment or surgical treatment. We don't want to go for surgery in first instance. We can easily solve this problem by either medical treatment or supporting treatment. So what sort of medical treatment I'm talking about is like bisphosphonate, cyclical bisphosphonate at the interval of 3 months initially, then we can start or continue that therapy for 6 months interval to strengthen the bones or bone, and that is how we can strengthen the bone, and the bone density will increase and prevent further fracture. Not only fracture, that will also prevent bowing of the long bones also. Not only long bones, and the ribs and all other bones of the body will get strengthened. And when we give the child cyclical bisphosphonate, the x-ray of this child shows this zebra stripe sign. Each and every time a child goes through cyclical bisphosphonate, one white streaks appears at the growing end of the bone, and thus we can be sure that the bisphosphonate is also working. Along with that, we need to prescribe some calcium and vitamin B2 because these childs are bedridden or they don't go to sunlight that much, and there is a possibilities that they may be suffering from calcium deficiency and vitamin D deficiency also. There is some controversy regarding the supportive treatment, like whether we want to go for braces, whether we want to immobilize the limb after fracture, how long will immobilize the limb. Uh, what we have seen, like if we go for bracing, then due to immobility or immobilization, the fracture may heal, and most of the time it's very rare that any fracture related to osteogenesis imperfecta is non-unioning. There is almost rare entity that non-union happens in osteogenesis imperfecta. Usually malunion happens. And but what happens if we put that leg into brace or foot into brace or the thigh into brace, the muscle that becomes weak, and these weak muscles then cause problem. And another problem that we face is like the limb or long bones of the leg or the thigh is bowing. In these cases, like putting some special brace over the affected part sometimes gets impossible. So we can also start supporting treatment regarding mobilizing that child for like wheelchair movement or crutch movement, if possible, if we are thinking like he can cope up with that. So we can also think about those crutches and wheelchairs also. And there is also always have like we can always go for surgery, but surgery is only for those child who has severe deformity and severe fracture and that needs attention, surgical attention. Otherwise, even we are saying that immobilization for the less period, it's not like you need to keep it for 4 weeks and then okay leave that immobilization and mobilize the child. Earlier mobilization is good in case of a child with osteogenesis imperfecta who are suffering with fractures. One of the mostly used method in surgical treatment is the Sofield-Miller osteotomy. Here, what we do is like we can go for retrograde or antegrade nailing, intermediary nailing, and when the nail passes or crosses the cora, then we need to go for osteotomy there. If needed, we can rotate the fragmented bone and pass away. By this way, we need to go from one end of the bone to the other end. I'll show you some x-rays and clinical pictures at the end of this slide so that we can be sure about that. So Sofield and Miller invented that osteotomy, and it is well practiced osteotomy that we usually use in osteogenesis imperfecta. And to put some intramedullary nail or pin, there are some telescopic rod that increases its length as the child grows old. So these are three vastly used telescopic rods that we use. In Bangladesh, we actually use the Fisher Duvel rod. It has two screw end, one female end and one male end. One is that means we can go for a retrograde fashion, then put the female end. We need to go through the fracture site or cora of the broken bone, and then we go proximally and distally and put this. The problem is we need to anchor these two ends along the epiphysis or physis, so that when the child grows, the end is kept as it is, but the male rod moves in between the female rod to gain length along with the lengthening bone. Uh, the Sheffield intramedullary telescopic rod is almost with the same principle, but here the end, the T end of the at the end, we need to put it later on. And all these three rods are with the principle on male and female rod, where the female rod is where the male rod guides itself in between within the female rods as the child gain its length. Uh, but sometimes these implants are actually not an ideal implant. It may be due to the operator. Sometimes this the child don't have that much marrow cavity. Sometimes they grow old and they grow their length. As the length of the child increases, these male and female coupling system become more and more weak. As they grow weak, sometimes they break down, they bend, and if we can't encode the end of these rods into the physis correctly at the center of the physis, sometimes it dislodges itself, sometimes proximally or distally. The main problem here we face is like we need to open the joint to put this male or female rod. If we want to go for the leg, then we need to go through the knee joint. Sometimes we need to fix the ankle also. If we, that is not if we fail to implant those implants into the correct position. So this is a problem, and we don't want to go for the joint also, but we don't have that much option in this surgical. Yes, we can go for Elizarov or ring fixators like that, but not everyone has that much expertise to go for Elizarov or ring fixations. I think, as I don't have. So the another problem that we face during fixing these fractures of osteogenesis imperfecta child is like we don't get that much marrow cavity so that we can put a female rod and a male rod. So we need to go for the old fashioned K-wire or rational fixation in these cases. Um, it's very tough, but we need to go for that. Exact diameter K-wire is also can also do the trick to fix that broken bone. So I'm showing one of my cases. Like this is a child, as you will appreciate, he has multiplanar bowing of this of his both lower limb, and that's also present in thigh to leg. And if we go for the X-rays, you will see bowing is there with one fracture on his left tibia. So as I was telling, multiplanar osteotomy is there. So what we did, we went through the ankle, then we fixed the ankle. But if you can see the ankle joint properly, we went a bit posterior from the talus. So when we'll remove that K-wire or K-wire from there after uniting the fracture, it won't be a problem. That child will have some sort of ankle movement there also. And in follow-ups, we have examined the child, and that showed good range of movement of ankle. In the mid segment, you'll see we have done two osteotomies, actually 1, 2, 3. From the proximal part, and the first osteotomy is there. When we actually went through the ankle. So the first osteotomy was here and the below part. Then we rotated that bone. And after that, when the tip of the implant touches the second angulation point, then we go for the second osteotomy and we rotated that bone again. And at the end, we passed that rod towards proximally, but we spared the physis. We don't want to hit that physis or injure that physis so that the growth of the child don't hamper that much. So post-operatively is like 27 days post-op. You will appreciate the left leg was operated first, right leg was operated first, and the left leg then second. And our goal was achieved. We have achieved a straight leg. Both of the leg are now straight. And in follow-up, I don't have those pictures, but in follow-up, he showed good union and good range of mobility of both ankles. So that's all from me today. Thank you all for your patience hearing.
Thank you, Dr. Quaisur Rabbi. It is the part of uh, question answer session. Dear participants, I have invited you all to write your questions to the chat box. So I have one question, that is, uh, how can you differentiate osteogenesis imperfecta fracture from child abuse? Dr. Quaisur Rabbi, how can we
Yeah.
differentiate a fracture of osteogenesis imperfecta and child abuse fracture?
Yes, obviously.
স্ক্রিনটা সরিয়ে দাও,
আচ্ছা
স্ক্রিনশটটা সরিয়ে দাও।
স্যার, এটা কিভাবে যে শেয়ার করবো বুঝতে পারতেছি, একটু এক
ওই
মিনিট স্যার।
তোমার স্ক্রিন শেয়ারটা সরিয়ে দাও, অফ করো স্ক্রিন শেয়ারটা, তাহলেই হবে।
ঠিক আছে, শেয়ার স্ক্রিন বাদ মে চলে।
Okay. So it's a good question. Thank you for the question. So you need to be elaborate during taking histories. Birth history is important, and along with that, you will find history like the child is showing clinical features of like blue sclera, and then bowing of the long bones, and age of the child is also important. Too early in the life, they don't have that much abusive fractures. Usually, after toddler, that you will get abusive fractures like battered baby syndrome, whatever we tell it. We'll get it after toddler. That means after 1 year or above. It's not necessary that it will be like after 1 year. But that will be there. And number two thing is X-ray will define like what I have told you, like the long bones will show few features that will define that these are osteogenesis imperfecta. The cortex will be thin, the diaphyseal and the metaphyseal region diameter is almost same. You will find the honeycomb appearance in the bones. Sometimes you will find multiple fractures with different age of healing. All this you will find it. It's not necessary that each and every child will present with blue sclera, but sometimes you will get blue sclera, sometimes there will be gray, and you have all the other features. You need to go, you need to look for other features like pot belly appearance is there or not, whether the child is showing any spine features. So you need to be vigilant to find out whether it's a battered baby or not. Thank you.
Okay, Professor Kori sir, would you please supplement something?
না ঠিক আছে, it is well covered.
Okay,
next question এ যাও।
Next question is from Dr. Tahfim Ehsan Kubir. He wants to know which bisphosphonate should be used to treat osteogenesis imperfecta and tell about its dose and duration.
Okay, thank you. Dr. Tahfim sir. So we usually use zoledronic acid. Zoledronic acid dose is like 0.05 milligram per kg body weight per day, per schedule. So what we do, it's available in market into two form. Either it's a 4 milligram in one vial form, or it's a 5 milligram form. And it's also from too costly to sometimes it's cheap also. The Bangladeshi companies, those who are making bisphosphonates, those are cheap, like 6,000 or 7,000 taka. Some multinational companies also use that in different names, but those are like 27, 29, or maybe 30,000 taka. So what we do is like it's 5 milligram of bisphosphonate, then you can dilute it in 100 milligram or 100 ml of water. So if you divide that, you will find like it's 0.05 milligram per ml of fluid. So what we do is per kg, we usually infuse that child 0.05 milligrams. So whatever the weight of the child, if that child may be 10 kilo, then you need to give 10 ml of that mixture. So obviously the 10 milliliter infusion is a bit problematic, but you can use microburette to infuse that, and that's easy. That one microburette usually contains 100 ml of normal saline. So if you want to go for that, what we do in our practice is we usually accumulate patients. Like it's not like one patient, then we are going for only maybe 10 ml of fluid and the rest 90 ml is wasted. Not like that. We usually accumulate like, okay, 5 or 6 patients. Then we usually calculate those weighting, and we need to just memorize that number 0.05 milligram per kg body weight. Whatever the body weight is, you need to find that dilute that 5 milligram into 100 ml of fluid, and then whatever the body weight is, you need to give that ml only. I think I'm clear. If Quaisur sir want to add something.
মনে হয় যেদিন you are correct 0.05 milligram per kg হ্যাঁ এটাই ডোজ কতদিন পরে পরে কতদিন পর পরে এটা বলো না
Oh, usually we schedule the initial 1 year. We schedule after 3 months, and then in between we need to go for the X-ray evaluation. That zebra stripy lines that I was showing in the X-rays, that will be well visible in the X-ray, and along with that you will find that the bisphosphonates are working properly, the osteoclasts are working less, so that the bone is getting strengthening. So the initial year will go for 3 monthly, every after 3 months. Then we'll reschedule to like 6 monthly. Okay, but if the child needs, you can go for 3 monthly schedule for 2 years also. It's not like that has that much side effect in this child only. You can go for 3 monthly schedule for 1 year, then 6 monthly schedule for the rest of the year, but you can change it. Thank you.
Okay, thank you.
But do you advocate with vitamin D with this?
Yes, I have mentioned that in my slides, sir. Along with bisphosphonate, we can go for vitamin D and calcium because these child are not getting sunlight, and most of the time they are nutritionally imbalanced also. It's not necessary that we can go for serum calcium and vitamin D, and then we'll get vitamin D is less. They can go for.
But doses and doses of vitamin D, how you evaluate the doses? That is, in injectable form, we get 2,000, most probably 2 lakhs. How
2
you?
lakhs.
Yeah, 2 lakhs. How you will give it?
So what we usually do, the vitamin D is like insufficient, sufficient, less. What in my practice, what I practice is like it's 2 lakh unit.
Yes.
I can go for like 15 days interval, 1 lakh unit, mix it with little water. Usually I suggest to mix it with milk, then 1 lakh unit every after 15 days. And we need to reevaluate that vitamin D level. If we are starting vitamin D orally, then we need to reevaluate the vitamin D level because we don't want hypervitaminosis. Yes, we know that that vitamin will also get lower in the event of time, but we'll also reevaluate that maybe in 3 months or 2 months. We need to find out that baseline, what was the baseline, and how long we want to continue that vitamin D. Orally.
Injectable form or oral form?
Sir, I usually prefer oral form. Joe is injectable, but we usually prefer orally.
And I know
with
that
milk.
Orally acts well rather than injectable.
Yes, sir. And that's also like at বাচ্চার বাবা মার জন্য ফেয়ারসাম না, আবার একটা ইনজেকশন দিতে হবে।
Okay, thank you, Medina sir and Quaisur Rabbi. Next question is from Kaji Shahidul Alam. He is asking, is there any minimum age of starting bisphosphonate?
In
Is there
literature,
any
I
minimum
haven't.
age?
Thank you, sir, for your nice question. I have not found that minimum age for bisphosphonate, but You can start that at 3 months, I think. Uh, what I have read through articles, they haven't mentioned any age restriction regarding bisphosphonate. But in my private practice, like if it's not type 2, you can wait for 6 months. Like it's type 2 is the most lethal form. And in that case, the main treatment is counseling. You can usually wait for 6 months or maybe 1 year. At least let the child show some clinical features so that you can go for bisphosphonate. It's not like okay, the child may have osteogenesis imperfecta and he is having some like cortical thinning, and you can wait for 6 months or 1 year to start. Let the child survive, and it's not like osteogenesis imperfecta has any treatment. We whatever we are doing is like it's the supporting treatment. Okay, so
Okay, thank you, Professor
thank you,
Quaisur,
sir.
sir. Can you hear me? Quaisur,
Yeah.
sir, what is your
Yes, yes,
experience?
yes.
What is your experience regarding the starting of bisphosphonate about the age of the child?
I usually start at about 6 months, but there is not much supporting literature, you know. So, as Dr. Quaisur Rabbi said that this is not the curative treatment. This is just a supportive treatment, but still we get some good results that refracture is reduced after this bisphosphonate. Main problem is fracture unites, then refracture again. But after
Yes.
this bisphosphonate therapy, the incidence of refracture is much less. That's why we use it. I usually start at about 6 months.
Okay, thank you,
6
sir.
months.
Next question is from Dr. Malay Rai. He is asking them, is there any ideal time of operation? From Dr. Malay
Okay,
Rai.
thank you, sir, for your nice question. There is no ideal time for operation. You need to operate to treat the child. It's not necessary that each and every fracture you need to operate. If there is not that much bowing and there's not that much problem, you can go for like a immobilization for 14 days, and there will be some callus there. And what in osteogenesis imperfecta, we always try to mobilize the child as early as possible. Huh? And those child who are not walking, we don't need to go for operation that early. If that bony fragment is not causing that much problem, you can treat it by conservative also. Like the first picture that I showed, he has like poking bone through his skin in my cover photo. So as I was mentioning, like collagen 1 distribution is huge. That's also present in skin also, the vessel also, fibrocartilage also. So if there is any sign that fragmented bone may poke outside the skin, you can go for operative procedure. If that child is having like bowing, like serpentine manners that I have shown in the X-ray, yes, you can go for operative procedure. And if you are planning like now it's time for that child to start walking, and that child may be presenting with some sort of fracture or not, but you need to straight that leg so that they can start walking, then you can go for operative procedure. But after proper counseling, that single operation is not going to end that disease. And you may go for secondary procedures also if you start your operating age like at 6 years. Like the baby is going to gain some length over the time, and that implant you put inside, that may fail. So in secondary operation, that may also need. So whenever I start or I plan to operate on a child with osteogenesis imperfecta, as I was telling, the main treatment plan is counseling. You need to counsel that parents. Those parents are so frustrating. Before operating, I usually think twice or thrice before operating, because that sometimes gives them false hope that this operation is gonna cure my child like 100%. That's not gonna happen. You need to make that clear. Thank you, sir. Kori sir, if you want to add something.
No, take that's fine. Your answers are fine.
Thank you, sir.
Because you must counsel the parents that this is not a cure. So this is very important. Maman, are any more question?
মিউট করা, মিউট আনমিউট করো, আফিফ আনমিউট মিউট আছে, আনমিউট করতে হবে। মিউট মিউট মডারেটর মিউট করা আছে, আনমিউট। মডারেটর প্লিজ unmute. Moderator please unmute.
Okay, thank you, sir.
হ্যাঁ,
Actually, I was muted by the host and I was not able to mute myself.
unmute.
Actually, I have one
ঠিক
question
আছে,
to
দাও।
Kori, sir. I have one question. Sometimes to fix the fracture due to osteogenesis imperfecta, we have to face some problems regarding the diameter of the bone. And we have to fix that by using some traditional K-wires or rush nail.
Well,
Sir, do you have any experience to use TENS, titanium elastic nailing?
No,
To
I
treat
don't
that?
have. I don't have
Like
that
so.
experience. Yes.
Okay.
I have one experience. If you permit, I can share.
Okay.
yeah.
So the cortex are so thin. So what we thought, like, okay, let's spare the joint and the physis also. Put some elastic nails from side, and titanium elastic nail, whatever elastic that is, that's still like a strong body. So we started putting that from the side, and after some moment, what we have seen, like, side থেকে চিড়ে গেছে স্যার, like a slit.
Slit,
হ্যাঁ,
slit.
হ্যাঁ, slit like. So
Yeah.
after passing that
Slit.
fracture, what we have seen, like, we haven't moved that much. এদিক থেকে ছিটতে ছিটতে গিয়েছে স্যার, ওখানে ফ্র্যাকচারের কাছে এসে আটকেছে।
হ্যাঁ।
So
না,
so it's better.
সেজন্য কেওয়ার দিয়েও রাখা যায় না, অনেক সময় কেওয়ার দিয়েও কর্টেক্স দিয়ে বের হয়ে যায়। কাজে নট
Right,
দ্যাট ইজি, বাট স্টিল রাশ নেইল দিতে পারলেও ভালো। রাশ নেইলটা একটু শক্ত বেশি। হ্যাঁ,
No, challenging, sir.
চ্যালেঞ্জিং,
Yes.
ডেফিনেটলি চ্যালেঞ্জিং।
Definitely
খুব
challenge.
খুব অপারেশনও ভালো জিনিস না, আবার না করেও উপায় নাই, প্যারেন্টসদেরও বোঝানো মুশকিল। তবে ওই যে রাব্বি যেটা প্রথমে বললো যে কিছু কিছু প্যারেন্টস আছে সবকিছু বলার পরেও বলে যে স্যার কিছু একটা করেন যেন আমার বাচ্চা হাঁটতে পারে, এন্ড সামটাইমস দে আর ভেরি কিন এবং খুব হেল্পফুল। তখন প্যারেন্টসরা যদি হেল্পফুল হয় তাহলে তোমার রেজাল্ট ভালো। বাচ্চাকে যদি হাঁটাইতে পারো তাহলে রিলেটিভলি বোনটা একটু শক্ত হয় মোটামুটি। দৌড়াদৌড়ি লাফালাফি করতে পারে না, কিন্তু হাঁটতে পারলেই খুশি থাকে। হ্যাঁ, তো সেই জন্য দিস আর ভেরি ইম্পর্টেন্ট। আর সাবজেক্টটাই তো ডিফিকাল্ট সাবজেক্ট। হ্যাঁ, এটার তো কিওর নাই, শোনো, মুশকিল তো সেইখানে। যাই হোক, তবুও
স্যার একটু অ্যাড করব স্যার।
হ্যাঁ, বলো।
So one another thing, like, আমরা যখন এই যে মাল্টিপ্ল্যানারি অস্টিওটমি করি, যদি আমরা ক্লোজ করার সময় যদি পেরিওস্টিয়ামটা ঠিকমতো ক্লোজ করে দিয়ে আসি, ইভেন দ্যাট হেল্পস। হ্যাঁ, আমরা অনেক সময় ভাবি কি যে না, ঠিক আছে, অ্যাঙ্গুলেশন। হ্যাঁ, হ্যাঁ, অনেক সময় বোয়িং এর জন্য পেরিওস্টিয়াম দেখা যায় দূরে সরে থাকে, দেন আনা যায় না কাছে। বাট যতটা পারা যায় কাছে এনে দিলে দেখা যায় যে বেশ ভালো হেল্প করে এতে, ইন দ্য লং রান
হয়ে যায়।
রাইট।
আরো তুমি যেটা বললা যে ব্রেস দিয়ে অনেক সময় মানে স্ট্রেট করার পরেও হাঁটার সময় ব্রেস দিলে হেল্পফুল হয়। হ্যাঁ, কিন্তু ব্রেস দিয়ে ইমোবিলাইজ করে রাখার জন্য না, কিন্তু ওয়াকিং ব্রেস, একটু ব্রেস দিয়ে থাকলে হেল্প হয়। হ্যাঁ, হাঁটার জন্য, যাতে একটু বাচ্চা হাঁটতে পারে, ইন এডিশন টু ইউর ইমপ্ল্যান্ট। অনেক সময় আমরা প্লাস্টার দিয়েও হাঁটতে দেই, ওয়াকিং প্লাস্টার, যে ঠিক আছে পা একটু সোজা করে দিছি কিন্তু প্লাস্টার দিয়ে হাঁটতে দেব, প্লাস্টার দিয়েও হাঁটতে দেই, তারপরে আস্তে আস্তে প্লাস্টার খোলা আর কি। তো ঠিক আছে, অনুমান আর প্রশ্ন আছে?
Sir, actually in my chat box there is no question. So can we hear some of experience of Professor Mofakkar Rabbi, sir?
হ্যাঁ, বাড়ি স্যারের দেখো যে ইলিজারফের হেল্প করতে পারে কিনা।
Bari sir, please, you can share your experience regarding the treatment of osteogenesis imperfecta. Sir, please
স্যার আপনাকে
unmute yourself.
আনমিউট করতে হবে।
আনমিউট করতে হবে স্যার।
হ্যাঁ তা বাড়ি
Okay, thank you. Ji, assalamu alaikum, everyone. First of all, I'd like to congratulate Quaisur Rabbi. Well explained everything regarding the classification and other, regarding medical management, regarding the biphosphonate. Before 3 years, if you start, you can get three things. Number one, muscle mobility is very important. Muscle strength, mobility, and at the same time that I have mentioned here, self-well-being of the patient. Regarding this is medical management of regarding the biphosphonate that you rightly said. 3 cycles every 3 months. That is good before 3 years, that I know. And literature also says. This is the one thing. Regarding the surgery, because bone is very fragile, microfractures, lot of deformities. The deformities, very severe deformity. What I know, type 1 is very good. 2 and 3, result is not good. Even then, if you do with Elizarov, what I have seen in Kurgan Center, they are using titanium elastic at the same time combined with Elizarov, or only with thin biocompatible wires to make the bone stable and gives the stability of the deformity correction what you are doing. And when you are correcting the deformity, you can cut short the bone so that you can align the bone easily without going for shick above different levels. Here, multiple deformities you can see, Cora 2 and 3. 2, obviously you'll get all the type Tora. That is true effects of the deformity in 2 levels. So even then, you rightly said, and Quarid also rightly said, counseling of the patient. If you tell the patient, parents, your child will walk nicely, and regarding prognosis, we must advise the parents, the prognosis is not good. And even then, the relatives of the patient, that is parents, they want so that patient can walk. But unfortunately, this is a long-term disease, just like a diabetes and blood pressure. And so we shall have to counsel the patient. Thank you very much for hearing and giving me the time. Assalamu alaikum.
Thank you.
Thank you, sir.
Thank you, Bari bhai.
Kamrul Alam Saleh sir is here. Sir, Kamrul Alam Saleh sir is here. Kori sir.
আছে কামরুল
Ji sir,
বলবেন
Kamrul Alam
কিছু?
Saleh sir. Sir, can you hear me? Kamrul Alam Saleh sir. Kamrul Alam Saleh sir, can you hear me?
না শোনা যাচ্ছে
Okay,
না মনে
Kamrul
হয়।
Alam
আনমিউট করেছেন কিনা স্যার?
unmute করে নাই। Kamrul Alam Saleh sir, please unmute yourself and share your experience. He is connected, but I think
দীপঙ্কর নাথ তোমার স্যারকে একটু বলো, স্যার মনে কানেক্টেড কিনা দেখো, ওনার কিছু এক্সপেরিয়েন্স থাকতে পারে।
দীপঙ্কর নাথ স্যার কানেক্টেড আছে। দীপঙ্কর নাথ স্যার, আপনি একটু বলেন স্যার।
হ্যাঁ দীপঙ্কর,
দাদাকে খুঁজে পাচ্ছি না তো, এই জন্য দাদার
Actually, very nicely explained by Dr. Quaisur Rabbi. It is the heterogeneous group of diseases. Actually, it is in the literature, it is about 19 types, 19. Among the 19th latest type is X-linked recessive disorder. এটা একটা ইনফরমেশন আমি দিলাম। এবং latest treatment is coming, cell therapy and gene therapy. The purpose is to suppress the mutant gene and production of the aggressive wild genomic products. That is the diversion of the mutant genes to the other productions of the other collagen tissues, which are helpful for the baby. These are coming recently. Cell therapy and gene therapy. This is the latest update. It is, sir. 19 subtypes আছে আর তো some of the literature says about the bisphosphonate therapy the dose schedules below the 10 years 10 বছরের পর পর্যন্ত আমরা 4 মিলিগ্রাম দিতে পারি উইদাউট irrespective of body weight, but below 10 years the dose schedule sometimes some literature 0.08 to 0.16 milligram per kg body weight 0.08 to 0.16 এটাই লোডিং এটাই আর কিছু কিছু ইন্ডিয়ান স্পিকার বলে যে 0.03 0.5 মানে হাই ডোজ পর্যন্ত বলে 0.05 to 0.3 সাম অফ দ্য লিটার্স একদম আমরা লেকচারে শুনেছি আর কি এই আর তো ডিউরেশন তো কাইসুরবি বলতে আমরা 5 বছর পর্যন্ত দেওয়ার পরে মাঝে মাঝে ব্রেক দিব এবং ব্রেক দেওয়ার পরে যে অ্যাটিপিক্যাল ফ্র্যাকচারের যে চান্স থাকে ওটা কিন্তু টোটালি মানে এলিভেট হয়ে যায় ব্রেক দিতে হবে
কমে আর কি কমে যায় রিকারেন্সের চান্স কমে
এই জন্য চান্স কমে যায় এবং এই ধরনের ক্ষেত্রগুলো ব্রেক দেওয়ার পরে অ্যাটিপিক্যাল ফ্র্যাকচার হলে তখন ওই আদার অন্যান্য মেডিসিন দিয়ে আমরা ট্রিটমেন্ট করতে পারি যেমন থাইরোক্যালসিটোনিন বা আদার মানে আইনোট্রপিক ড্রাগস থ্যাংক ইউ স্যার
Sir,
আমার মনে হয় যে
I am Dr. from Molvi Bazar.
হ্যাঁ
What is the average life expectancy period of the osteogenesis imperfecta patient? Average lifespan period, how much?
কাইসার রাব্বি বলো
Thank you for your nice question. So life expectancy actually depends on what type of osteogenesis imperfecta
টাইপ
he or she is diagnosed with. If it's type 1, so it's like almost 80% of the osteogenesis imperfecta patients are like suffering with type 1. It has a good prognosis, and life expectancy depends on how many fractures that child is suffering with. In case of 2 and 3, so life expectancy is not that much. You can like fix that life expectancy to like 3 months, 6 months, but life expectancy is not that much. In case of type 2 osteogenesis imperfecta, sometimes intrauterine death also happens. In case of 1, that's like it's confusing. What I have seen in my life, the age patient of osteogenesis imperfecta in my life is like 23 years old with 18 fractures and 3 surgeries, and most of the fractures they treated with like only brace and immobilization for 14 days, but 3 major surgeries were needed for the lower limb. Other than that, maybe Quaisur sir may share with us.
আমার মনে হয় আমাদের এক্সপেরিয়েন্স হইলো যে লাইফ এক্সপেক্টেন্সি যেটা বললে যে টাইপ 1 তো এটাও ভেরিয়েবল, টাইপ 2 তে তো লাইফ এক্সপেক্টেন্সি কমই, আর টাইপ 1 এর মধ্যে আমার নিজের পেশেন্ট আছে স্কুল টিচার, তার আবার বাচ্চা হয়েছে, ওইটারও অস্টিওজেনেসিস ইমপারফেক্টা আমরা চিকিৎসা করতেছি ছেলে, হ্যাঁ তো সে তার ওরকম 10-12 বার ফ্র্যাকচার হয়েছে, ইউনিয়ন হয়েছে ওই ডিফর্মিটি নিয়েই, শর্ট স্ট্রেচার উইথ ডিফর্মিটি, and this man had fracture of the upper limb as well, upper limb or deformed, কিন্তু এই নিয়েই সে পড়াশোনা করে ডিগ্রি পাস করে স্কুল মাস্টার, মানে এটা আমার এক্সপেরিয়েন্স আর কাজে একবারে খুব প্রগনোসিস খারাপ তা বলি না আমি, পেশেন্টকে বলা যাবে না, দ্যাট ভ্যারিজ, কিন্তু মাল্টিপল ফ্র্যাকচার হয় এবং সেগুলো যদি ওয়েল ট্রিটেড হয় এবং বাচ্চার প্যারেন্টসরা যদি ভালো কেয়ার নেয় তাহলে দেয়ার লাইফ মে লিড এ অলমোস্ট নর্মাল লাইফ। কিন্তু
স্যার আই ক্যান শেয়ার স্যার। স্যার
হ্যাঁ বলো।
বলবো স্যার, এটা লাইফ এক্সপেক্টেন্সি যে কোশ্চেন করছে এটা ভেরি ইন্টেলিজেন্ট কোশ্চেন। ইট ডিপেন্ডস অন দ্য ভ্যারাইটিস, তো আছেই, কারণ এভারেজ ডিজিজের দ্য লাইফ এক্সপেক্টেন্সি ইন কেস অফ দ্য ইট ডিপেন্ডস অন দ্য সেক্স। পুরুষের বেলায় 10.3 ইয়ার্স কমে যায় স্যার নর্মাল লাইফ এক্সপেক্টেন্সি, আর ফিমেলের বেলায় 7.8, 8 বছর। এটা বইয়ের কথা, এটা লিটারেচার 10.3 বছর নর্মাল লাইফ এক্সপেক্টেন্সি নর্মাল পার্সনের থেকে কম পুরুষের বেলায়, আর ফিমেলের বেলা 7.8 বছর
যাই
কম,
হোক, ওরকম,
এভারেজ আর কি, এভারেজ তারা স্টাডি করে দেখছে আর কি। আর যেটা ইন্টারউটেরিন, যেটা ইনফেন্টাইল কনজেনিটাল, ওটা তো ফিটাল লাইফে অথবা 5 জন্মের কয়েক সপ্তাহ পরে, এটা নয়, নরমাল একটা যেটা আমরা পাই, যেটা ট্রিট করি,
টাইপ 1 আর কি, টাইপ 1।
টাইপ 1 তো শুধু ব্লু স্ক্লেরা হিরো হিসেবে ট্রিট হয় স্যার। ব্লু স্ক্লেরা নিয়ে ওটা তো আসলে ওয়ান্টিং সামথিং।
এদিকে মাথা ঠিক আছে ওদের।
ঠিক আছে, আমার মনে হয় যে এখন আমরা শেষ করতে পারি। হ্যাঁ, আজকে সাবজেক্টটা ডিফিকাল্ট ছিল। আচ্ছা নোমান,
স্যার,
হ্যাঁ তুমি কি জানো যে নেক্সট এটা কি?
নেক্সট টপিকটা স্যার রোমেল স্যার পরে জানাই দেবে স্যার, পরে সার্কুলেট করে দিবে বলছেন।
আচ্ছা, হ্যাঁ,
তো আমরা শেষ করি স্যার, নাকি স্যার?
হ্যাঁ, তা ঠিক আছে, আমরা সবাইকে ধন্যবাদ দিই।
সো গুড
আজকে
নাইট।
সাবজেক্টটা ডিফিকাল্ট ছিল। হ্যাঁ, এবং কাইসার রাব্বি, he had a very good presentation, presented well.
Thank you, sir.
Thank you, Kaisar Rabbi. Thank you, Numan,
Thank you,
for
sir.
conducting this session. And thank you, everybody.
So good night from my side, and thanks you all to participate and have a good experience and knowledge from Kaisar Rabbi, from Kori sir, from Dipankar sir, from Bari sir, from Mehdi sir. Thank you all.
Thank you. Thank you,
Thank
Numan.
you all. Assalamu alaikum.
Thank you.
Good night.
Assalamu alaikum. Thank you, Kaisar Rabbi.
Ah.
সুন্দর প্রেজেন্টেশনের জন্য।
Thank you very much, sir.
Thank you.
And we'll
Assalamu
circulate the
alaikum.
next schedule in time. Romel sir will circulate the next topic on from the Facebook page of USP.
বিদায় নিতে স্যার।
Okay, thank you.
Thank you. Assalamu alaikum.
Assalamu alaikum.
যদি হয় অনলাইনে পড়াইব, রাজি হইছো?
অনলাইনে কোনো সমস্যা নেই, সে পড়াইবো কিনা?
অনলাইনে কেমনে করবো? ওই কম্পিউটারে?
কম্পিউটারে বা মোবাইলে, তাইলে দুইজনের আইডি লাগবে, তোমার আমার।
আইডি মানে
দুইজনের মোবাইলই করতে হইব, তাহলে তো সে মনে হয় তোমার মোবাইলে যুক্ত। তো উপরে ঠিকঠাক করে দেবো।
ওইটার নামই তো ওই নামই। খালি ফোন এসে যন্ত্রণা করতে। ওটার নাম আমি 11 রাখছিলাম, জায়গিয়া থাকে না এটা। আমি পয়সা দিয়ে মাস্টার রেখে পড়াইতেছি কি অসুবিধা আমার লোক এইটাই নাকি
18-20 তারিখে ওই
যন্ত্রণা দেওয়ার একটা নাম্বার আছে এটা তুই ফোন দিতে পারিয়া সরাসরি কোন জায়গায় একটা নাম্বার জুম মিটিং ইন প্রগ্রেস
সিনেমার নায়কের মতো ডায়লগ